If they can't do that still, then we have to figure out like why that is, right? Still can't touch your toes. So we're looking at this, okay? If they're getting to 80 degrees, then we're assuming this whole 80-degree thing is basically looking at normal lumbopelvic rhythm. Pelvis has to rotate. You can see how this happens here. Pelvis rotates up, okay? It means they have to have enough hip flexion to do this, okay? So let's say it's a scenario where it's not getting to 80 degrees. This could either be a hip restriction problem, so maybe there's a bone spur here that's preventing the pelvis from translating over top of the femurs. Maybe their hamstrings are really tight, right, connecting on the ischial tuberosities, and it's not allowing the pelvis to translate forward. Or their hip flexors aren't strong enough to actually pull them into this position. Right? We still don't know at this point, so that's why we have to go through more of the breakouts. Now, we could have a situation where they're here, the sacrum's not getting to that 80-degree mark, yet they can still reach forward and they can touch their toes. Again, the spine's hypermobile, it's compensating for this, and it's going through excessive motion to allow them to get to their toes. So they could still have low back pain here, because it's working harder than these structures. Again, putting more motion into this, adjusting these areas, may not be helpful for this individual. Soft tissue's hypermobile, joints are hypermobile. We can take some of the strain and stress off these by actually improving hip mechanics, getting the pelvis to translate over top of the femurs easier, okay? Which again, it could be, do we have a restriction here? Maybe there's a spur here we can't change unless they're gonna go have surgery, right? There's nothing you can do about that. We modify their movement, and when they're in a standing position and change their foot position maybe to help kind of clear that osteophyte, yeah, maybe. Is there just tightness in the hamstrings we need to stretch? Or do we just need to go through and do some hip flexor exercises to help pull the pelvis further forward? Okay, so that will dictate what you do for your treatment. Okay, so we go to that seated test first, and there's a lot to kind of interpret on that one. Okay, so we go through all these breakouts, right? They can't get to their toes, then we're figuring, okay, well, why is that? So that's why we go through and have them do their active straight leg raise. Do they get to 70 degrees on their own? Okay. They can do that by themselves, then you're saying, well, they have adequate strength in their hip flexors to pull their leg that far. They have adequate flexibility in their hamstrings to get them this far. And obviously, they're not running into any kind of bony impingement because they can get their leg into the 70-degree angle. Right? They can't. Then we follow up and say, well, maybe there's a core problem here. So we go into doing the stabilized version. You guys have a picture for that one, I think. Right? You got updated slides. So with this one, this is where the patient's gonna have their arms up here, and we're gonna push. Okay? We say, well, we push there, that if they were to live in a bit of an anterior pelvic tilt, right? Pelvis is tipped this way, that if we go through and we contract and engage the core here, that it causes a little bit of a posterior pelvic tilt, and it changes the orientation of the acetabulum. That brings it forward a little bit, which provides clearance to the hip. Notice how I do this? It makes it a lot easier to do this versus if it's in that kind of neutral position here for this skeleton. Neck of the femur is going to run into the acetabulum sooner. Then if you do this, it gives it some kind of clearance. So if they live in that anterior pelvic tilt position by engaging their core, they're just going from here to here, and all of a sudden they go from, hey, I failed the active straight leg raise, to all of a sudden, hey, now I'm passing it. That tells you they have a problem with their pelvic orientation, the position of their pelvis, and it has to do with core control. So you do give them core exercises and teach neutral position of the pelvis.
The difference from active to passive will only be like, or from active to stabilized will only be like 10 degrees or something, right? Because the pelvis isn't going to tilt more than 10 degrees.
So you may have somebody who does this. It is, well, for whatever reason, they're only getting here because it's still, there's a stability issue to a certain extent and a motor control problem. Again, the stability happens from core proximally and moves distally. So they have a disconnect there. By providing some kind of stabilization through the core and the trunk itself, that might also engage psoas better, may engage hip flexors better. So you will, it's kind of crazy how we go through and you're in a seminar with a lot of people doing it. You might actually have somebody here at like 45, and also you do the stabilized version, and they literally go through and they pass it by double. So we go through and do stabilized. Then from there you go into passive. So there's no change with the stabilized. So active, they fail. Stabilized, fail. Right? Then we go through and we passively go through our passive straight leg raise. We're expecting that we should be able to go through that and get past what they can do. You should be able to do that for everybody. So even if they get to 90 degrees, you should be able to go through passively and move them to about 100. Okay? If you're running into the same wall, so they're failing this test, they get to 60 degrees, and also you run into 60 degrees, there's just a wall there. That tells you that there's some kind of mobility issue. Could be in the hip, could be in the hamstrings. And we don't know where yet. However, you go past that. They're only getting to 60, okay? So actively they're going through, they only raise their leg up to here, all of a sudden I go through and passively go through this, and we're like, ooh, okay. That's more than 10 degrees. That tells me they just have a weakness problem here. They don't have the strength to control this motion in their hip flexors, okay? Again, treatment's then, hey, we're gonna strengthen your hip flexors. You run into the same wall, then you're saying, okay, is this hip flexor or hamstring? That's why we go through and do knee to chest. We're taking the hamstring out of the equation. Saying, hey, do you actually, this is like the hip scour test. Can I actually get your hip into this position? 120 degrees. Because I'm assessing this joint doesn't have full flexion, 120 degrees. So if you're going up through here and you run into a wall less than 120 or something here, and we start seeing the pelvis dip up, right? If I go through and I hit here, this is all going to move as one unit, right? I'm just running into a bony block and everything goes through a posterior pelvic tilt. That happens. Again, we have a bit of a restriction here. We mobilize this, maybe we have to alter their movement and help them go into this position potentially. They're lifting things, okay? We gotta take the hamstring out of the equation. Yeah.
There's another question. When you say strengthen the hip flexors, are you saying like eccentrically strengthen them, or both eccentric and concentric?
Both, but usually when a muscle lacks eccentric control, eccentric strength, that's when it becomes guarded. So if I don't have so if we think hip flexors, right? If I don't have the ability to go through and eccentrically elongate to get to this position, it's gonna start to protect that range, right? So they know I'm only strong enough to go to here, so let's limit this motion and prevent you from going into extension. And then that's where it's gonna be weak, and it's gonna usually go into a shortened position because it doesn't want to elongate. And at that point, it's also short and weak. Now, if they pass this test, that tells you they have tight hamstrings. Your treatments, can we do some kind of soft tissue mobilization to relax the hamstrings and sort of give some kind of stretching that will help elongate those structures, improve the range of motion. Everything's looking good there. Then we want to finally go through and look at, does the spine go through flexion? So a lot of times you have people go through and they're doing multi-segmental flexion, and you'll see very, very specific spots are going through flexion, and then everything's straight between maybe two segments. So you want to see a nice uniform curve and the ability for them to actually get their chest down to their thighs. Relax there and see that nice uniform curve. If they have a hip restriction, they struggle to get into this position, right? Because it's greater than 120. You can see probably a bigger pelvic tilt, and you can start to see some kind of different kind of changes through the spine too. Okay? So that's your breakout, that's the interpretation of multi-segmental flexion. Multi-segmental extension, anywhere we have like a restriction or a kink in this chain, this kinetic chain, it's typically gonna reduce this global motion. So you'll have reduced multi-segmental extension, you just don't know why. Could be from the ankle, could be from the hip, could be from the spine, could be from the shoulder. So we have to go and tease that out. So like I said, you can go through and start in any position you want. It doesn't really matter. You could start the shoulders and work your way down, okay? Which is typically kind of what I would do. If we're going just for spine, then we go through and say, hey, can we go through and actually extend the spine with a nice uniform curve? All right, so again, hips have to stay within 2 inches of the floor. They pass this after failing the multi-segmental extension, then you'd say, well, they have a weight-bearing stability problem. Standing, they can't control this motion. Fail that, then we go into, hey, is there actually a spinal extension problem? So we start with thoracic spine. Okay, it's producing a good majority of the extension and rotation in the upper body. So we look at the lumbar lock position first. See that they rotate 50 degrees. If they don't, then we go into our passive assessment. And we go through the passive assessment, wrapping our hands kind of underneath in front of the shoulder and trying to do it for them, right? So again, same thing like the active straight leg raise, passive straight leg raise. If actively they fail this test and then passively you go in and you pass it, they have a motor control problem. Give them strength training, give them some exercises. You run into the same wall, then that confirms that they have a mobility problem. It's a mobility problem anywhere in the thorax. That's my kind of advice to you, that you don't look at just, hey, it's just a thoracic spine vertebrae extension problem. It could be anything, maybe a mobility issue through soft tissue of the obliques, abs, maybe there's a rib issue, right? You have to kind of look anywhere through the thorax. So that was our active and passive. Go prone on elbow to check the lumbar spine. Same situation here. We have to do it actively and then you do it passively. We cleared the spine's good. Then we either go shoulder, we can go hip. Active shoulder motion. We just have them face down on the table and we have to see, can you actually get your arm into an extended position? Actively under your own power, right? Face down on the table. It's going to be a little harder for them to do this. So if they pass this right from the get-go, you're like, shoulders clear, they're good to go. Okay. If they don't, then passively you're going to go through and say, hey, can I actually get their arm in that position? You'll see this a lot where you go in there and you try and get their arm into a neutral position or that 180 or 170 degrees of flexion, and you just run into the same wall. Okay. You run in the wall and then you start feeling this posterior tilt of the scapula because everything is moving as a unit then at that point. Okay. Clear the shoulder, because again, if I get to this point here and that's all I have for shoulder flexion, what am I going to naturally do? I'm probably going to start to go through lumbar extension and do one of these things. My lumbar spine starts to become irritated because I don't have that full range of motion of the shoulder. Okay? Yeah.
I was just wondering, can we just rule that out by first when the patient is going, multi-segmental extension with arms overhead, getting him to do that same extension with arms down by their sides. And if their lumbar spine is the same position, then that means their shoulder, it's not their shoulder contributing to it.
Yep.
Can you do that?
Yep.
Okay.
It's one way, yeah. Saying eliminate body parts, right?
Right.
It's kind of like doing the multi-segmental rotation. You have to sit down, you're taking the elimination of the lower body so you can go through and just assess the upper body. That's one way of doing it, yeah. A lot of these you can start to tease out. Again, so I said this at the beginning. This is SFMA. I'm not teaching all of SFMA. And SFMA has changed a little bit over time, but you can sort of tease things out like, hey, we do multi-segmental flexion. Could you kind of try and tease out one side at a time? Good, by putting one foot on top of a step or something. Good, there's nothing wrong with that. So we're going through active and passive for shoulder flexion, then we're just going into the hip. So if the shoulder's good, then we're going to assess the hip in the situation. Again, with both feet flat on the ground. We're going through lumbopelvic rhythm of extension. So we're going to need a little bit of extension through the hips and external rotation because the hips are fixed. So we're going to go through and do the Faber test, okay? If they don't have the full range of motion where they're not getting their legs all the way down within 2 fist width of the table, right? So we're just doing Patrick's, right? Doing one of these things. Here, right? They're not within 2 fist widths of their hand size, okay? And we're saying, okay, let's do the stabilized version again, right? See what happens if that kind of repositions the pelvis and gives them better external rotation. If it does, then we're saying that's a core control problem. If they fail that, then we go into doing a modified Thomas position to see if that's also restricted, okay? We go into this position and we're looking for, does the hip get into a neutral position at bare minimum, and do we have enough flexibility through the rectus femoris so the tibia is hanging in a vertical orientation? That's not, those structures on the front side of the thigh, whether that's the psoas or the rectus femoris, if they're tight, right, they're going to restrict some of that extension. We might even see some abduction of the leg. We might see some external rotation. Those are clues that maybe the piriformis or the TFL, something on that lateral side, is basically pulling the leg into that position. These are just passive, so they should be able to get to these positions without any kind of effort. Okay? Good with multi-segmental extension. Okay, rotation. And we're looking for 100 degrees of total of rotation. So if they're standing doing this, we have to see that kind of if you're standing behind the patient, or I guess in front of the patient, you have to see the opposite shoulder kind of peak past that 90-degree mark. If they're going through the full 100 degrees, then we want to see, is the pelvis rotating 50 degrees? So we want to see 50 degrees from the lower body, 50 degrees from the upper body. So we're going with the scenario that doesn't happen, okay? So they're not getting the full 100 degrees of rotation, or not getting the 50 from the lower body. And we're going to put them in the seated position. Remember, with the seated position, we have to have them cross their legs over, okay? The leg that crosses over the one side, that's the side we're going to rotate to. And that kind of positions the pelvis so it stays stable on the table so they're not cheating by rolling up, rolling side to side. And this is just evaluating the spine and see if the spine can go through rotation. So again, this is thoracolumbar. We're getting the majority of the rotation from the thoracic spine, but the lumbar spine is contributing to some of that rotation slightly, right? 10 degrees or less. So if they go through and they pass that, that's why we're going into assessing the hips. There are assessments for the tibias, but we didn't go through that portion, okay? So we're looking at hips. Do they go through internal and external rotation? So again, we can do this actively. Patients are face down, right? Have them go through it actively. Can they get to 30 degrees of internal rotation? And can they get to 40 degrees of external rotation? They do this actively, they pass, right? You're done. But if they don't, then we're going to go through and we're going to have them stabilize again. So this is where they put their hands on top or underneath the kind of table and pull up, try and engage that core a little bit. And then does that change things again? Because it changes the orientation of the pelvis. That doesn't change, then we go passively to say, hey, can I get them further? Because if you get them further, then it's a motor control problem. If you can't, you run into the same wall they are. Okay? This is pretty common, right? So we're saying 30 degrees of internal rotation. People have issues with internal rotation all the time. So we get here, and you're doing Hibbs or Eli, and you're like, oh, geez, this person's pretty stiff, and you can't move their leg at all. Okay? They have a mobility problem in the hip. If their hips don't move and don't rotate, they're going to have a hard time rotating here. So then we're looking at, do we need to mobilize the joint? Do we need to mobilize the soft tissue that surrounds this joint to allow it to move better? Yeah.
Just when it comes to stabilizing that pelvis, do you just contact the ilium or the sacrum and the ilium? Or how would you go about this? So we're going to have the stabilization of that pelvis works.
So when we have, you're saying like when they do it actively, you mean?
Right, right.
Right? So we say actively bring your leg out this way, right? So if they run into a wall, what are they naturally going to do?
No, but for you, like, I thought you're supposed to stabilize the pelvis.
Yep.
It says on there, like, stabilize the pelvis and then have the patient lower the leg or rotate the hip externally.
Yep.
He's
getting-
talking
I'm
about
getting
the
there.
contact, like where would
Yeah,
you
yeah,
contact?
yeah.
Stabilize.
Yeah, I'm getting there, I'm getting there.
Oh, okay.
He's going this way, right?
Right.
So what are they gonna actually do? If they run into a wall, what are they gonna do? They're gonna cheat. So where am I gonna contact? I'm gonna place my hand right here. I'm not necessarily gonna stabilize and hold it here. I just wanna say, hey, I'm gonna put my hand right here. Because if I feel it all of a sudden coming up this way, yeah, I can tell that they're compensating. They're getting to here. And generally, okay, we're saying 30 degrees, right? So if they get to 30 degrees and I have somebody who's like really competitive, oh, like they have no idea what I'm looking for. Maybe they're thinking like, hey, he wants me to get my leg all the way over here. So they get to 30, and all of a sudden I start to feel this kind of, because they're gonna cheat, right? So then I can get an idea of when that starts to happen, if it's gonna be on that opposite hip, right? I go through here, right? What are they gonna do? They're naturally gonna run to a wall, they're gonna wanna cheat and go this direction, right? So again, I'm just gonna contact right here and say, hey, can I feel and detect, when is that starting to happen? Is it right from the get-go? Like, right, is it fused? Can they have problems like disassociating this movement to this movement? Yep. Any other questions? So you're gonna go through and you're just gonna go from one to the next, the next, the next, the next, a lot of the time. So it's not really necessary to go through and be like, yeah, I gotta go through, like, for this. You just know these, kind of the order, like, if somebody fails this, where are they gonna go to? They're gonna go to the next one. That's for the lab practice, that's what you need to know, like, hey, this finding tells me I need to go to this next thing. Or if they pass this, then I would go to this, or if they pass all the shoulders, so they have an active prone shoulder, if they pass that, oh, then I would go through and I would assess the spine and the hips.
In practice, do you go through all of the initial exams right away and then like mark down where they failed and then do the breakouts? Or do you, when you find it, then you do the breakout?
No, you go top tier first. So you have global screen, right? Where do I need to, because you don't want to go through and just start doing all the breakouts for no reason potentially, right? So you go through top tier first. All right. Good? Okay. All right, so quiz, we have 5 questions, okay? So within the notes, we see they were there, right? So our initial contact was here, our toe off was here. So this is our stance phase, this is the swing phase. When we look at the pelvis, this is right side, this is left side, that means basically in between, because when we run, you're running from one foot to another one, right? So there's this float phase where you're floating through the air. So essentially when you're running, you are hopping from one leg to the other leg, okay? So you're landing on one leg and basically you have to sit there and land and you have to control for any of this kind of sway in the frontal plane, anything with rotation in the transverse plane, okay?
Yeah, sorry to asking one of the questions, but on that previous chart, when it comes to that swing phase, I tried to understand that swing phase, why it's going like that sinusoidal pattern. I couldn't. Can you explain that? Yeah, can you just explain that how that works?
So it's gonna vary from person to person, right? So as we go through the case today, you'll start to see like, oh, that kind of looks weird, right? So if I don't want to give away the answers.
We'll get to it. Yeah, we'll get to it.
Can you see how if all of a sudden my swing phase might be different if my pelvis is here?
Oh, well, for sure. Just didn't
Versus
understand
my
how it would
pelvis
come
is
up
here?
and down like that, but yeah, we'll get into it.
Okay. So you have a case that's on Moodle, right? Look like this. Okay. What I want you to do is I want you to go through, and I want you to just quickly go through and review each of these. And I want again, the whole point of this is that, think of it like an MRI. If you've gone through and you've done your evaluation, whatever that evaluation is in practice, and you're still running into kind of a situation where like, I'm not really sure what's going on and this person's not getting better. yeah, you can send them out for MRIs and all that other stuff, but that may not provide you with the right information. So this is like an MRI. This is one way of saying, hey, this is maybe where these little tight spots are, or maybe these errors exist in this person, and maybe this is where you need to look, okay? So the easiest way to go through and evaluate this and make sense of this is to go step by step. So, okay, this is the ankle. What's happening here at the ankle, okay? And you may have to kind of get up and move around and get with your partner and be, okay, what are the positions that I'm seeing here? So is this person more in this position, and place these body parts in positions based on what you're finding from this result, okay? Remember on this one with adduction, abduction, we're talking about the foot. Forefoot, foot, abduction, adduction is internal and external rotation, okay? Not calcaneal inversion, eversion, okay? So position your partner or yourself or whatever in all these different positions and see if you can make sense of it, okay? I'll let you do that for a little bit, and then we'll come back together and discuss kind of the findings, okay? Go ahead.